Can you guys hear me okay?
Yes.
We'll just wait a few moments since we're early. We get one more fellow, we'll get going. Yep, and we got one. Okay. Let me just see here. Sounds good. Okay, why don't we start right here? So this is an electrocardiogram that was obtained on a patient who was being evaluated for heart murmur. So David, what do you think about this?
Okay, so just looking at our ECG here, the rate looks to be about, so it's less than 100, maybe something around 90 beats per minute. Looking at our P waves, we have P waves upright in 1, upright in AVF, and looks like sinus rhythm. Our axis also looks normal for age. Looking at our, intervals and looking at the progression of the P waves. Now that I'm looking at our, I kind of see triplicates. Now that I'm looking at our rhythm strips on the bottom, I'll see 3 beats and then a pause and then 3 more beats. Now I'm just kind of trying to march out our P waves here.
Mm-hmm.
So I do see a, starting on lead 2 in the bottom there, I'm seeing progressively longer PR interval. So the first one, the second one longer, then the third one longer, and then we have a skipped beat. So it looks like it would be, it looks like it's Wenckebaching because after that, because it's getting progressively longer, and then we have a skip beat, and looks like there's 3 beats and then a block. I also see looks like an RSR prime in V1.
Mm-hmm. So so if you were going to formally interpret this, what would you say this is?
So I would say that it's second degree heart block type 1.
Mm-hmm. And the other, and how would you describe the QRS pattern?
It looks like it's narrow complex or 3.
Well, you think it's narrow? Is that a normal appearing QRS for a 12-year-old?
Let me see here. It's like 3. It looks like about 3 small.
V3. Is that a normal appearance?
V3. No, in V3, it's definitely wider. I mean, I kind of commented on that RSR prime in V1. Right. And let me count that out here. More like 1, 2, 3, 4. So yeah, so it's about 4 boxes. So it'll be 160 milliseconds. So it'll be kind of wide in those.
I mean, yes. I mean, I think you could call this either interventricular conduction delay, or you could just call it an incomplete right bundle. But this is sort of a patient who now has essentially two levels of block, right? They have Mobitz 1, Wenckebach, as you appropriately and correctly diagnosed. And again, I'll just remind everybody, and I think you were hinting at this, David, the grouped beating. When you see beats 3 or 4 in a row and then a little bit of a pause and 3 or 4 in a row and a pause, that is very typical of Wenckebach or Mobitz type 1 second degree heart block. That's always a good hint. And of course, as you properly identified, the PR interval is lengthening. And David, when patients have Wenckebach, where is the most common level of the block? Is it typically in the AV node or is it in the His-Purkinje system?
I believe it's the AV node.
That's right. It's usually at the level of the AV node, which is typically usually considered to be less dangerous. But this patient, has Wenckebach and has an incomplete bundle. And so there's definitely some conduction disease going on here. So let's say you're seeing this patient in the office. Is this a normal finding in a patient being evaluated for a murmur? Let's assume Dr. Parnes examined the patient. He didn't agree that there's a murmur. So the only abnormality is this electrocardiogram at this time. Is this within the normal range of what's seen in healthy patients? What do you think about that? Is Wenckebach ever healthy or normal? And if so, when?
From what I understand, having both of these conduction abnormalities would not be normal together. In terms of, second degree heart block in general, I've seen cases where, after speaking to electrophysiologists who weren't too concerned in an adolescent patient that just had some intermittent first degree heart block, but second degree usually was something that we followed.
Mm-hmm. So I think the point I'm trying to make is I generally agree with what you're saying, but Wenckebach, when a patient has very high vagal tone or is very deeply sedated, such as during the middle of the night, is a very common finding in healthy young people, particularly athletic people, but even unathletic people. It's very common that on the Zio or a Holter or a Barty device at night, the patient will have Wenckebach. But this is somewhat unusual to have Wenckebach in an awake patient who is well. Now, if this patient were an 800-meter runner and was the finest in the state of New York, perhaps we would give him a pass and say he's just got very high vagal tone. But I would say that this is an abnormal finding that needs to be evaluated in somebody who is just 12 years old and doing this awake. And the first step, I think, would be to perform a Holter monitor to make sure that where there's smoke, there's not fire, and that this is as bad as it gets. And this is certainly something that would need to be followed because this is not a normal observation in patients. I think in this particular case, the patient actually had congenital heart disease and was known to Dr. Parnes to have that. Let's move on to the next tracing. All right. So let me see if I can hit up Dr. Bonsall, who I saw studiously pushing an echo machine at 6:30 in the morning. What is the mechanism of tachycardia in this tracing, Dr. Bonsall?
Good morning, Dr. Pass.
Good morning again.
Good morning again. Let me just look through.
I will tell you just for clarity that this is atrial extrastimulus testing. You see here S1, S1, and then an S2 is put in, and tachycardia then is induced. And I would remind you always when you're looking at EP channels, EP intracardiac cases, you always want to look at the legend on the left-hand side. So you have 4 ECG leads, high RA, 1 His channel. In our lab, we usually have 3, or 2, I'm sorry, but here we have 1. And then the coronary sinus, all they're giving us is proximal coronary sinus, distal coronary sinus, and then finally right ventricle. So now I will shut up and let you analyze.
as you said, there is first one, like extra stimulation one, the first beat, and
So just for clarity,
mhm,
S1 by convention is the drivetrain. It's the rate at which we're beat. Remember, we're paced for 8
mhm,
beats at a certain rate, and then we put in an extra stimulus. And the first extra stimulus is typically S2, and then you could put in double extra stimuli and have S2 and S3. You could even have triple extra stimuli, S2, S3, S4. So S1 is the drivetrain, and S2 is the first extra stimulus, just so that we're all on the same page.
so I'm looking through with these second extra stimulus testing, we can see in the distal coronary sinus that there is a V,
Mm-hmm.
and then there is an immediately A following the V,
Mm-hmm.
like the retrograde A wave or P wave or whatever. Ventricular atrial conduction is earliest in distal coronary sinus. So I
Yes.
think this is conducting through the accessory pathway
And
that is
where would it be located, Perna?
laterally on the left side,
The left side. Well, we don't really. Yeah, I guess so. Since we don't.
because of distal coronary.
Right.
That's why I picked
Right.
lateral.
So again, just for that was excellent, Perna. You just got a point on your
Thank you.
boards. So again, if you look here, the earliest retrograde A. So we have an extra stimulus. We're going A, H. This is the histoflexion V, and then we're coming back up an accessory pathway. And as Perna properly identified, the earliest retrograde A is actually in the distal coronary sinus. You see that this atrial electrogram is earlier than this electrogram, and then look how late the atrial electrogram in the His is compared to the distal CS. And this is the high RA, which is often placed either in the lateral right atrial wall or in the right atrial appendage. And that A is very late in comparison to the distal CS. So this is clear evidence for the existence of a left-sided accessory pathway. So this would require, therefore, either a transeptal or a retrograde approach from the aorta. Very good, nice. Okay. These questions are getting too easy for you smart people. Okay. Let me ask is Dr. Babia on the line? Yes, of course he is. Thank you. Good morning, Sergey.
Good morning.
This is another intracardiac tracing. What do you think is going on here? Is there anything wrong? And if so, what?
Give me a moment.
Excuse me.
So I see the first four legends are telling us that these are the surface EKG leads, and then we see the high right atrium and His bundle.
Yeah, and so again, let me interrupt and say that was perfect. That's the first thing you should always look at when you're looking at intracardiac tracings. And you notice how different this is displayed than this prior tracing, okay? This is why every lab and every question you would ever be asked is going to be displaying it in some different manner. So that's why it's always very important to do exactly what you just did, which is to look at the legend first so that you know what channels you have, what channels you don't have, and what you're looking at. And the order in which the channels are on the page is very variable depending on the particular operator. Some operators like to see it in a certain way and others in a different way. I'm sure you guys in the lab have noticed that there is a Dr. Love protocol for ablations and a Dr. Pass protocol. Ours are fairly similar, but point is that everybody gets used to seeing it their own way. So I'll stop interfering and just let you keep talking, Sergey.
Well, I'm looking at the, it looks like that in the high right atrium, we see the atrial electrical signal for the contraction the A's.
We'll call an electrogram.
Electrogram, sorry. And then in the his bundle channel, we see the AH and V, and we see the intervals shown that it's AH is to 50 and HV is 45. And I believe the HV is normal. It's usually 35 to 50 milliseconds. And AH, I'm not sure how normal it is.
Well, what is a normal PR interval?
120, I would say, up to 120.
No, I mean, we don't know the age of this patient, but right, in an adult-aged patient, up to 200 would be considered a normal PR interval. And what is the AH measuring, Sergey?
It's the conduction from the atrium to the his bundle.
Okay, but why do we measure that? What is that a surrogate for? Why do we even assess that in an EP study?
Well, that's a surrogate for, I guess, the AV node, maybe how long it takes to conduct through the AV node.
Right, because remember that the His catheter is sitting across the tricuspid annulus and the anterior annulus, and so the atrium, the atrial signal is very close to the His at that location because you can only record from the electrode that the His is recording from. So by definition, it's pretty close. And the other thing to remember is that the AV node does not actually make an electrogram on an intracardiac study. So we infer AV nodal conduction by measuring the time it takes to go from the atrium to the His in the His catheter. And that is a surrogate for AV nodal conduction because we cannot actually record an actual AV nodal signal. Now, I've heard people say that if you were in a perfectly electrically neutral environment, you would be able to record the AV node. But the bottom line is in practice, in clinical practice, you cannot record the AV node. You can only record the impulse or the electrical signal immediately above the AV node and immediately below the AV node. And we infer that the time it takes to go from the A to the H is the length of time it takes to go through the AV node. Okay, so the AH is generally the intracardiac surrogate of the PR interval. So if I told you a patient had a PR interval of 250, would you be pleased with this observation?
No, as you mentioned, it should be less than 200. So I would suspect a first degree heart block because I don't see any prolongation.
That's right. So the AH is long, but the HV is in the normal range. As you said, the normal HV is roughly 35 to 50 milliseconds. So this is an example of an intracardiac example of first degree heart block. And so this could be for any number of reasons, which we'll go over later. But I think the bottom line is this would be an abnormal finding. A normal AH interval is probably anywhere between 50 and 150 milliseconds. Okay. The PR is really the A to V interval. So it's really from the A to the onset of the V. So you really have to sort of imagine that this is a very long PR and this is clearly abnormal. Presumably, we would never do an EP study just for this observation on an ECG. So I'm guessing that whoever recorded this tracing caused this, and this is what we have, fortunately. You don't want to see this in the EP lab if you started with a normal AH. Okay. This is a 12-year-old who is seen for chest pain. I'm going to ask Dr. Grace Kong of Manhattan, New York.
Good morning, Dr. Powell.
Good morning. How are you?
Good.
What do you think we're looking at here?
So we're looking at, the first thing that jumps out at me is the prolonged PR interval.
Mm-hmm.
The P waves are upright into AVF, so it looks like it's coming from the sinus node. I don't think the PR interval changes in any way as we go through the strip.
Mhm.
And given that this is for chest pain, I don't see any PR depressions or ST elevations.
So how would you work this up, Grace?
I would send thyroid studies, Lyme studies, I guess electrolytes.
So you're looking for causes of
First
first
degree.
degree heart block.
Mhm.
Okay. Would you do anything else? I agree with everything you've said. Any other evaluation you would do at this stage?
The patient's pretty bradycardic from this. It looks like.
Well, yeah, a little bit, but not. But
Oh,
it is in sinus rhythm. It
yeah.
is very significant first degree heart block.
Anything else for this?
So you've sent a number of lab tests, all of which I agree with. But anything else you would want to do? You're in cardiology clinic. You accidentally trip over Jen Lau in the hallway. But,
We could get an echo to look for signs of myocarditis.
right, because you're getting a Lyme titer because you're worried about Lyme myocarditis, aren't you?
Yeah.
So you can have dysfunction, or you could have any kind of myocarditis. So you would probably also want to get some kind of a marker for inflammation, like a CRP or an ESR or something along those lines. So these are the more common causes of first degree heart block. First is, of course, damage from surgery, probably the most common that we see, actually. Then damage from catheterization, which is a close second. Hypothyroidism, as you just said, Grace. Myocarditis, particularly Lyme disease. We had a case last week of that. Rheumatic heart disease can cause first degree heart block, electrolyte abnormalities, and then finally just plain old idiopathic. That's probably the most common, honestly, aside from surgery that we see. We never figure out why the patient has first degree heart block. There are many theories about why people may have it. But, sometimes we wonder if patients had myocarditis in the past and it resolved and left the patient with first degree heart block. It's not, although we normally see, that this resolves with treatment or even without treatment, it doesn't always. And especially people with myocarditis can be left with permanent blocks. So one theory is that patients who present out of the blue with first degree block, who don't have a Lyme titer or a hypothyroid or anything like that, perhaps they may have had myocarditis in the past, but we don't really know, of course. Okay, a lot of first degree heart block today, and Mobitz 2, Mobitz 1. Okay, so this is patient that I saw. This is actually, I believe, a 12-month-old. And I think we'll go to Neha Alwalia, whose name I see here.
Morning, Dr. Bass.
How are you?
Good. So
Rhythm here. This is a patient that I was asked to see as a consultation from another cardiologist. That's all I'll say.
Right. And do we know the age?
The patient is actually, as I'm thinking about it, I believe the patient is 3 years old.
3 years old. Okay. So looking at the rate, it is around, it's like bradycardic, so it's 6 boxes. So it's like 60.
Even a little slower, but
50, yeah.
Uh-huh.
So that's definitely bradycardic. There's P with QRS in some of the beats, in 1 and AVF. So those are sinus beats. I'm going to focus on the rhythm.
Let's take a step back.
Yeah.
Are we in sinus rhythm right now?
No,
Is the atrium in sinus rhythm?
I mean, the P waves, I have to look at the relationships in the rhythm strips, but anyway,
right. I'm sorry for interrupting you. I apologize. Just do your analysis and then we can discuss it. Sorry.
Okay. So, I mean, the P waves, just looking at the P waves, they seem to be coming from the sinus node based on the morphology on lead 1 and AVF, which are upright. But looking at the relationship with the QRS, they don't seem to be marching out. Looking at V1, the first beat, don't see a P wave before, but maybe we're missing part of the strip. But then there is a P with QRS, then there is a P at the end of a QRS. Looks like the third P is very close to the QRS. Not sure if that's the conducted one, but the RR seems to be marching out regularly. So I think this is third degree heart block, complete heart block.
Mm-hmm.
And let's see anything else. The axis also, like the QRS, is down in 1 and up in AVF. So it's sort of a rightward axis for this 3-year-old.
Mm-hmm.
And then
I agree with everything you've said so far. What do you think about what's going on in the atrium? Look at, so you're right. The R to R interval is not changing at all.
mm-hmm.
So, and there does not appear to be an obvious pattern of conduction at all, right? Almost
Mm-hmm.
every P wave is a different distance from the QRS.
All right.
But do you think that the atrium is in sinus rhythm?
I guess in terms of they're not marching out in a way that, let me see. Is it like you're saying that they are blocked? No. Is this atrial bigeminy of some sort?
Yeah, that's
Yeah.
right. It looks to me, and I think to you as well, right? It looks like this is perhaps a sinus beat, and then this is
PSA.
PAC, and this is a sinus beat and a PAC,
PSA.
because this P to P interval is not the same as this P to P interval.
Right.
So at least for part of this tracing, the patient is in atrial bigeminy,
Mm-hmm.
but none of the P waves are conducting.
Mm-hmm.
Okay, so you've met this patient now for the first time. What are you going to recommend for this patient, or what do you want to do with the patient?
I mean, if the patient's coming in clinic, he's probably he's like hemodynamically stable. But this is.
If you want, I can. If you wanted to ask the family any questions, I can ask them and share with you what they had to say.
Sure. Like, why were they showing up to the clinic?
They were showing up because the cardiologist was concerned about this ECG, but as far as they're concerned, their child is great. Loads of energy. And I might add, every single time I've seen a patient with a finding like this, it is almost guaranteed that the family says something to the effect of, this child has more energy than any child I've ever known. Complete heart block is a marker for outstanding levels of energy. Okay, so this is a very energetic young patient. She's got a lot of energy.
I mean, sounds like this would be a long-standing case. If it was a new sudden onset, it would probably have some sort of symptoms, I would assume.
I will tell you that this patient has been known to be in complete heart block since 1 year of age. Okay, that makes sense. So, I mean, probably the family knows about this, that the patient's in heart block, but if the kid had it from 1 year of age, I'm guessing it's probably, it could be related to maternal lupus or any antibody mediated heart block in infancy, as we see. And I would say, so the question is that, do we need to do anything? Or correct.
So
how would you decide that? So you're very convinced that the patient is quite energetic.
Yeah.
But,
I mean, I would just do an echo to make sure there's, the function is still fine.
What would you
This is-
expect on the echo?
With heart block, I mean, I guess with long-standing heart block, you can get cardiomyopathy, but that's related to, I think, pacemaker mostly, if there's an issue.
And
But
cardiomyopathy from some of the causes of heart block, but most patients thankfully do not. But is there anything else you might expect to see on an echo of someone with complete heart block chronically?
effusion, is that?
No.
No. Some dilations.
Dilation. They
Dilations,
all
yeah.
get dilation uniformly, 100%, because, right, the only way to increase your cardiac output is either to increase your heart rate or your stroke volume.
Stroke volume.
And you can't really increase your heart rate very much in the setting of complete heart block. And so almost always patients with complete heart block develop some dilation of the left ventricle. So that's a very routine, common finding.
Right. And the other thing I would worry about and do a Holter with these patients is if they're having like long pauses, or, that they're going periods where there's like no ventricular escape basically. That would be concerning, or a history, which doesn't sound concerning, but if there's like syncope or anything, basically trying to see if we need to put a pacemaker now, or we can go a little further.
Right. So let's just go over the class 1 and then the class 2 indications. So class 1 would be advanced second or third degree AV block with symptomatic bradycardia, dysfunction, or low cardiac output. So patient doesn't have that. Sinus node dysfunction and correlation of symptoms from bradycardia. Patient doesn't really have that. Postoperative advanced second or third degree block, more than 7 days after surgery, that's not expected to recover, does not have that. Congenital AV block with a wide QRS escape rhythm or complex ectopy or ventricular dysfunction, patient doesn't have that. Congenital third degree block in the infant with the ventricular rate less than 50 to 55, or with congenital heart disease and a ventricular rate less than 70. And then pause-dependent VT with or without a long QT interval. Then for the 2A, which you remember are the recommended, generally most people would recommend, although not definitively needed, would be Brady-Tachy syndrome and the need for long-term antiarrhythmic treatment. Congenital third degree AV block beyond the first year of life with an average heart rate less than 50, abrupt pauses in ventricular rate that are 2 or 3 times the basic cycle length, or associated with symptoms due to chronotropic incompetence. Long QT syndrome with 2-to-1 AV block or third degree block. An asymptomatic patient with sinus bradycardia with complex congenital heart disease with a resting heart rate less than 40, or pauses in the rate more than 3 seconds. And then finally, patients with congenital heart disease and impaired hemodynamics due to sinus bradycardia or loss of AV synchrony. So we did a ZO in this patient. Actually, the referring physician did a ZO in this patient and identified at least 2 episodes of 5 to 7 second pauses. So based on what I just read to you, congenital third degree AV block beyond the first year of life with an average heart rate of less than 50. This patient's average heart rate was like 45 or 46 and had abrupt pauses in ventricular rate that are 2 or 3 times the basic cycle length. So the family wanted to repeat the ZO. I told them that it was adequate in and of itself, but the repeat showed actually a 5-second pause. So this patient is going to have a pacemaker implanted. So now the patient is 3 years old. So should this patient go to the congenital heart surgeons for an epicardial system, or would you favor a transvenous pacemaker in this patient?
I know you usually say 15 kilos is the
That's right.
sort of...
Generally 15 kilos, but again, So this patient was, I believe, less than 15 kilos. So it's going to go for a epicardial device. And would you put in a single chamber or a dual chamber? What's the advantage or the disadvantage?
I mean, if you're doing an epicardial, you could do dual to get sort of AV synchrony. And yeah, I guess if we can, then we should do.
What's
dual.
the downside of that? Or
What's the downside of dual? Not sure.
well, for an epicardial system, it's a much bigger operation.
Right, that's
You
true.
have to do a full sternotomy in order to
Expose the atrium and ventricle. Yeah.
and so generally, a lot of people would do a dual chamber in a patient like this. Certainly not wrong, but my personal bias would be to just place a VVI system in. In older patients, we've talked about this thing called pacemaker syndrome, where they have asynchronous V pacing and patients feel pounding in their neck. It's a very uncomfortable feeling, which is one of the reasons why in an adult patient, you would never place just a VVI pacemaker unless they were being very rarely paced. However, in a patient who's young, virtually never hear that symptom. And so I would probably favor a single chamber device because it's a smaller operation. Now, if you were going to advise the surgeon on where to put this pacemaker wire, Dr. Lualia, where would you recommend it?
So I know there are recent papers, and I don't know if that's the new consensus. Usually we do it on the right ventricle.
Why do we normally do it on the right ventricle, or have we put it on the right ventricle?
Just to prevent anything on the left ventricle, the systemic ventricle. I don't know, to prevent not putting it in the right way, but to avoid like a scar tissue from the epicardial leads to be on the LV side.
That's an interesting theory that I've never heard advanced before, but okay. No, the reason we put it on the right ventricle, or traditionally why it's been put on the right ventricle, is because it's technically much easier for the surgeon to reach the right ventricle, right? Remember, the right ventricle is anterior. And you can sometimes even access it through a subxiphoid incision. The traditional approach is to just do a subxiphoid incision. You don't even sometimes even need to open the sternum, or only have to do a very small part of a mini sternotomy, inferior border, to do this. So that's the reason it has been done there. But actually, it turns out that LV pacing is actually superior in general.
Right.
You know, every single patient has, shall we say, a sweet spot. And it's been shown that I used to work with a guy named Henry Spotnitz at Columbia, who still is very active in research, although not practicing any longer. And Henry used to have this experimental glove that had like 300 electrodes on it. And in animal studies, he would, the key is, with biventricular pacing, when you're pacing from two sites, can you find the optimal location either for two sites or one site? And what he found was that in these experiments was that they would put this glove, someone's hand would be in it, obviously, and put it on top of the animal's heart, and they would pace in various different combinations and from different sites. The computer would basically try like 1,000 different permutations. And it turned out that in every single animal, there were 2 or 3 locations where cardiac output increased tremendously, like 20, 30%. The problem is that every single person's sweet spot is different. And that's the problem. And I remember actually at the time that Dr. Spotnitz was doing these experiments, there was a patient who was doing poorly after open heart surgery, an adult, and they got special permission to bring this tool into the operating room. and they identified the best location and they put temporary wires there, and the patient was markedly better. And when the temporary wire accidentally fell off the heart, the patient got very sick and they had to urgently go back to the OR to replace it. But the point is that there is a perfect spot for everybody, but it's different in everybody. So people have looked to see if there's an area that might be better on average.
Mhm.
And it seems like LV pacing almost always is superior to RV pacing. And generally, LV apical pacing is the preferred location. The danger is not so much scarring, but that you'll injure a coronary. So you have to be very careful, obviously, to see the anatomy well. And it requires more dissection, of course, to go out a little bit more laterally and posteriorly into the LV. That is, in fact, what I've asked Dr. Murthy to do in this patient, is to place an LV epicardial pacemaker lead in this. And would you put a bipolar lead or a unipolar lead?
Bipolar. Bipolar.
Yes.
At a 50-50% chance.
That's true, since you've probably never seen a unipolar permanent pacemaker, but is there an advantage to bipolar?
I think you'd said that you can reverse the direction to capture if that's an issue.
Actually, interestingly enough, you cannot.
With bipolar, you cannot.
Can do that. You can do that at the bedside. You're right. Like at the bedside, when we're having trouble getting capture, it's not uncommon that we'll take the two wires out and reverse the polarity. But interestingly, with the most common epicardial lead used is this so-called capture fix epicardial leads made by Medtronic, where there are two little pods that the surgeon sutures. There are 4 suture rings on each of the pods onto the heart. And but when you plug that into the device, you actually cannot, I don't know how it decides, but it chooses which direction it's going to pace in. But the real reason that you would probably go bipolar, first of all, in general, you don't have to worry about stimulation, right? Most epicardial leads are placed in the abdomen. And if you have a unipolar system, then one half of the bipole is the actual device itself, which could result in some current drainage, which can cause stimulation of the abdominal musculature. Patients can have twitching in their abdomen, which is uncomfortable. It's not dangerous, but it's uncomfortable and it's a little scary to the patient. The other thing is that it's been demonstrated, the group in Michigan has a very, very, very large experience with epicardial pacing in congenital heart patients, and they've published a number of papers demonstrating that bipolar leads in general have better longevity than unipolar leads. Remember, although we cannot choose the polarity, meaning which direction it's pacing, if one of the pods were to lose contact with the heart, the device can pace unipolar. You can try unipolar. So if you have a bipolar lead and it stops working at some point, you have the option of pacing unipolar. And sometimes if the correct pod is attached to the heart, you can get away with pacing unipolar through a partially broken bipolar lead. So in general, bipolar leads last longer. The disadvantage is you need more myocardium because you have these 2 pods instead of 1 pod. So it's a little bit more complicated for the surgeon because they have to sew on 2 pods. But generally speaking, it's been my experience that most surgeons do not find this particularly difficult. But it is an interesting difference or observation. So yes, so we would recommend an epicardial bipolar lead and either single or dual chamber, depending on your belief system. Okay. And we'll do this one last case today. I don't want to feel as if I am abusing the only one chief fellow. I do see Dr. Obiaka there. Good morning, Uzo.
Good morning, Dr. Paz.
So this is a 1-day-old with an irregular heartbeat. This is from an EP conference that I did many years ago with fellows who are now long-time attendings. So what do you think? What do you think about this? You're called to the well baby nursery because they heard an irregular heartbeat when the when the pediatrician examined the patient.
Okay. So going through, like you said, it's an irregular rhythm. The heart rate on the average, again, I know it's irregular, so I probably will not speak to the heart rate.
And we will not speak to it.
The QRS was a narrow complex, and it does seem in the beginning of the strip to be like a sinus appearing rhythm. If I look at 1, 2, and AVF, but when I look at the strip, so they look grouped in a way. So looking at the lead 2 at the bottom, so we see there's a PQRS that looks normal appearing in the first 1, 2, 3, 4 bits. And then by the 5th bit, there's a cluster, there's about 3, where it almost seems like there's, if I convince myself, the QRS there seems to be wider. And there seems to be like a retrograde P, maybe not so much in the first bit, but in the second I see, and in the third, I see what might be retrograde P waves. And then we have a pause, and then we go back to, like I said, the normal 1-to-1 PQRS that appear normal, and again we go back to that wide complex QRS.
What are we going to call this?
So is this, and the QRS morphology is different in both groups. So is this some intermittent ventricular rhythm?
Yeah, so this is essentially an accelerated ventricular rhythm, similar heart rate to sinus, although a little faster. So what are you going to do? They desperately want to send the baby home, as they always seem to when they call us to the well baby nursery. Would you agree with that? Would you do something different? What would you do here?
So I will not send this baby home.
I would agree.
I will want to investigate further and get a sense of what is going on. I would send electrolytes, but like you say, the lights are almost never the reason why we have these. But I would,
not unreasonable thing to do, but agreed. It's unlikely to show anything.
We already have this baby on. I mean, I would place this child, since it's inpatient anyway, I would put this child on the monitor so I would get a sense of what's going on.
Okay.
I would also get an echocardiogram as well to make sure we don't have, I would be looking for things like maybe non-compaction, which could give us a ventricular rhythm. And also for function, to make sure that these are not causing some dysfunction.
That's right. So I agree with everything you've said. So, the natural history of this in babies is that this resolves over time. But you would certainly want to know what you're dealing with in the baseline. Usually this is not a hemodynamically embarrassing observation in a baby. But if you saw that maybe 50% of the beats are PVCs, you might consider treating it. I think it's unusual that we have to treat this. Almost always it just spontaneously resolves on its own. But you would certainly not send the patient home like this until you had a handle of how much it was. I agree, I would do an echocardiogram looking for the function particularly, and then move forward from there. All right, we're getting close to conference time. Thank you very much for joining, and I'll see you guys in a few minutes.
Thank you.
Thank you, Dr. Pass.
Thank you.